Hi, I'm Jeff Dreher, and I'm here to tell you how you can fix your ER and hospital, how you can remove those headaches that have been chronically bothering you at your job so that you can do what you love, which is take great care of your patients. I'm presenting this at the TOC in Healthcare Conference, which is the way that we're going to solve this problem by managing our emergency department better. So, hi, I'm Jeff Dreher, and I have trained extensively in emergency medicine and also in quality and performance improvement. And the problem that we have with emergency medicine is that patients wait for care, which causes their quality to be poor. Why does that decrease quality? Because door to treatment time denotes how sick people are going to be. And we have trouble seeing patients rapidly at times because the ED gets clogged up. It gets clogged up with inefficiencies in our department, and it also gets clogged up with admissions that are waiting for beds to become upstairs. And this causes problems. We're also waiting for test results. All these inefficiencies just seem to add up and snowball into making our work environment not the greatest place. And the result is stress and burnout, not because we're taking care of sick people, because things don't go well, and it's those what ifs. What if I could have gotten to that patient more quickly? What if I could have treated their stroke more rapidly? Maybe they would have just gone home and taken care of themselves instead of going to a nursing home, hemiparetic, drool pad, feeding tube, can't speak, wearing a diaper at a nursing home. Not the outcome that we want. And we know that if we can get to people quicker, we can drive great care. We just need to unclog this ED. So I want to make an important point here. Why is it so important to work on the entire system that delivers care? Why can't we just work on local problems like in the ED or in the lab or in surgery? Because what happens is that hospitals run at such a high occupancy rate that it influences the other departments and causes backups in the entire department of surgery and the emergency department. Why is the ED so important to offload? Because we are the major admitter. 70% of all hospitalized patients came through the ED. In university hospitals, that's about 45%. But I was actually at a hospital this week that had 85% of all of their hospitalized patients walk through that ED door. So keeping the ED flowing will keep the waiting down, because waiting destroys our door to treatment times. We can't treat things rapidly if people are waiting in our lobbies for long periods of time. So to improve the quality, to improve the ED, to improve the entire system, and to reach our goal, we must improve the entire system. So as my career went on, I noticed that the technological advances in medicine greatly outweighed the improvements in hospital operations. When I was in med school, we treated heart attack with aspirin, nitro, and morphine. But now the technology has been so advanced that they actually do a cardiac cath and they percutaneously can balloon open a heart artery without even cutting anywhere. It's amazing. But the advances in operations haven't changed much. So some people still wait for care. We need a balloon to balloon open our hospital so that we can get that flow going. So the problem stems from waiting. Waiting causes overcrowding, which causes more waiting, which causes more crowding. Overcrowding. So hospitals respond to this overcrowding by simply diverting away emergency squads. They turn on the no vacancy sign. So they do this because they believe that they are out of capacity. But I know that capacity exists. It's just hidden behind inefficiencies, bottlenecks, process issues that gridlock the entire system. So I know there is a solution, and that solution is TOC. So what if I told you we had a solution that in 6 months is going to add a fully staffed 12-bed ED pod to your emergency department? I can hear doctors and nurses jumping up and down with joy because we have been begging for this for many years. More staff, more beds. And what if, in addition to adding that 12-bed ED pod, we're actually able to solve a problem that's been chronically affecting our emergency departments nationwide? The overcrowding, the problems with quality, and the fact that the Wall Street Journal knows it's so bad they actually had to report on it. We're going to solve all those issues. And what if we had a system, a solution that could eliminate these never events? This is one of the reasons why we need to really help and improve healthcare. This is an extremely tragic case of a high school senior who had a full ride scholarship to an Ivy League school. He was the captain of his rowing team at the end of his senior year when he developed a scratch on the back of his leg. He was an Olympic hopeful. He developed a scratch which worsened over the weekend, went to the emergency department and had delay in care. Tragically, he had a disease called necrotizing fasciitis, which is that flesh-eating bacteria. And the treatment of this is amputation. So he had multiple surgeries and amputations and eventually left the hospital 6 months later with no legs. This young man's life was changed forever because of delay in care. This should never, ever happen. Can you imagine being a staff member that took care of him? What they were feeling if we could only have gotten to him sooner, if we only would have recognized it. This is what's causing the stress and burnout in healthcare. And what if, in addition to getting rid of the never events, adding the 12-bed fully staffed ED pod, you can tell your hospital administrator that he can rest comfortably because we're going to increase the overall hospital revenue by 9%. He can loosen the purse strings and now finally train our staff, add innovation, and things that we need to run this hospital. So the solution that's going to help us in healthcare is called TOC, the theory of constraints. It was invented by Dr. Eliyahu Goldratt, who is a Einstein level or above Einstein level genius who saw that in systems that we are not meeting the goal because there are constraints in the system. And there's usually only one or two constraints, even in complex systems. So what is TOC? So you need to first identify what is the goal of the system. Think of it as a systems level. What is in the way of the entire system for meeting the goal? Identify that constraint. Improve the efficiency of that constraint. Focus all efforts on this. Don't focus your efforts on anything else but removing the problems and improving the efficiency of the constraint. Put measures in place that keeps the constraint in check and manage the constraint, focusing leadership and management on constraint. So how can we do this in healthcare? Well, you ask any frontline person and they'll tell you what we need. We need more beds and more staff. It seems like the bed and a staffed bed is our constraint. But that bed will often sit idle 8 to 10 hours during peak times of the day upstairs when we are backed up. And it's a system problem. Admission backups in the ED are backed up because of constraints of the bed upstairs. So how can we relieve this? Well, the constraint is managed. It's never left idle. When there's somebody waiting to get into that, it's never let empty or idle or sat dirty. It's always turned over rapidly. We improve the efficiency of people and their care when they are in that actual constraint resource. And we manage that constraint. And it's like hitting the turbo button on improvement. It's really wonderful. And I'm going to show you an example of that on the next slide. So this is the case study of a hospital that I first applied TOC on a system-wide fashion. So I was called to this hospital by one of the administrators that I had worked with in the past who said, come help us. We have a large hospital, 528 beds, busy 84,000 visit ED, long door to dock times. People are walking out without being seen. Quality is suffering and our operating margin is poor. Why is operating margin so important? Because without operating margin, we can't innovate, we can't educate, we can't refill empty positions. Operating margin is extremely important to a hospital. So I asked for some of their metrics. These are basic metrics, but extremely important to kind of highlight where problems are. So what you notice is that the door to doctor time is long and it causes people to walk out. They're left without being seen is extremely high at 12.4%. This is one of the highest in the country. The highest I've ever seen is 17%. So you ask yourself why, and it's because the length of stay in their ED beds is too long. The ED discharge length of stay is too long, and the ED admission length of stay is very long. So you need to really see what's going on in the environment to find out why these are so long. And the thing is that the length of stay is what is a throughput metric, but it also tells you what your capacity is. Because if you have no capacity, patients are going to wait for care and people are going to walk out without being seen. The only way to solve this problem is by improving your throughput. So here's another way of looking at this. So this is the census of the ED every hour of the day beginning at 6 in the morning. So you walk into day shift and half the ED beds are full of patients. The gray shaded area shows that there are admissions actually boarding in the ED when you arrive, clogging up your ED. So during the day shift, you actually fill up by noon and you are over capacity most of the afternoon and evening. And then at night, it actually decompresses because our arrival rate drops. But this gray shaded area actually shows the effect of the admission census in our ED on how it backs us up. These are the patients that have been admitted and waiting for beds upstairs, waiting for discharges to occur. This is our opportunity, one of the opportunities, I should say, and it shows the effect of this on wait time. Wait time just continually gets worse until the night shift comes in and decompresses the ED. So we were able to fix this by measuring, monitoring, and alerting the staff to take action based off of two metrics. And in the TOC world, those are called buffers. So what were they? It was the lobby. We measured lobby wait time and the longest lobby wait time. And we measured how many boarders do we have. When we became above spec limits on those metrics, we took action to find beds, empty beds, get the whole system involved. I'll show you more. It is extremely important to go to where the work is being done to see how the process is occurring. And what you notice in this emergency department is that the patients walked in and they were actually first seen by a security guard, that circled person who actually handed them a piece of paper and had them fill that out. An hour later, they actually went to see this paramedic who did their vital signs. An hour later, they went and saw this triage nurse who said, "We have no beds, but hopefully we can get you back." The whole time he had this huge swollen red arm. This is what necrotizing fasciitis looks like. This is a surgical emergency and this process needs fixed immediately. So what do we do to manage waiting lines? Well, queuing theory gives us an idea. It gives us a clue to how to fix this. So the thing about a waiting line is they are waiting for a person to do the work or a machine to do the work, and that time takes amount of time to do the work. So the way that you can analyze and improve a waiting line is by manipulating the factors in the queuing formula. So essentially you can decrease the wait by increasing the number of servers, or you can improve the capacity they have to do that work by standardizing their work. Cutting and streamlining their work, making it more efficient. You can also improve waiting by decreasing the time it does to actually do that work. You can decrease the variation in the service time, and that's exponential. Or you can affect arrivals. You can decrease the arrival rate, or you can decrease the variation in arrival rate and improve flow through your system. When you have a multiple queue system like we did in triage, what you do is you kind of try to eliminate queues by parallel processing and getting things to work together. So how do we do that? I'm going to show you that on the next slide, how we actually manipulate each one of these factors to improve things. So how can we decrease those variables? Well, we can improve the server capacity by simply just doing demand capacity management or load leveling or offloading the work. Do a 5S, make their workspace more efficient. Do the same thing basically to decrease the service time. Make it more standardized to decrease the variability. Arrival rate and variation are difficult in emergency medicine, but you can certainly try to schedule. But basically, the biggest bang for your buck is going to be in manipulating these top three variables. So how did we apply queuing theory to this problem? Well, what we did was is we put the paramedic actually out front while he's doing the vitals. The quick reg person is quick regging them. So this is a parallel processing at its best. And then they would go straight back, one piece flow right to the triage nurse, 21 minutes. So we decreased the service time and we improved the server capacity to actually do more work just by rearranging the process and using queuing theory and working on the constraint. So at the other end of the ER sits the charge nurse. She is the most trained and experienced nurse in the department. She can handle anything. And basically she's acting as an air traffic controller to see if she can get any of these patients to move that are in the department. And I asked her, are we backed up? Are we busy, backed up? She says, no. I said, why? She said, well, there's no one in these chairs. There's no ambulances that have parked anyone here, and I have no one back in my turnaround. And I haven't gotten any calls in the last 15 to 20 minutes. So no, we are not backed up. We are not busy. So I said, what about triage? And she looked over at this screen right here. Here's a blown up shot of that screen. All you see is a bunch of lines. And she goes, oh my gosh, triage is super backed up. There's many patients on this board. So there's no way in real time to tell that we're overcrowded unless you're really trying to look for it. So an hour later, after we've received 2 traumas, 1 cardiac arrest, and a stroke alert, the ER looks like this, where patients are pushed in the hallways and only the critical patients are getting attention at this time. Quality suffers. So what does the charge nurse do when this occurs? Here's another charge nurse. She goes into overdrive. She scrolls the EMR, and what she looks for are icons. Is there a D icon, discharge icon? Can I send that patient home? Is there an A icon? I can send that patient to an admitted bed. Is there a medically cleared icon on a psych patient? I can send them to the psych unit. So she whacks this mole, makes all these alerts, calls nurses, voiceovers them over her little alert button, and actually gets this tech to actually also help to get patients moving. And then what she does is go back to her normal, pace once she gets it cleared out enough. It's reactive, it's not proactive. So why is this problem persistent and why is it so common in emergency medicine? Because it's impossible to promote flow before or when the system's over capacity. We don't manage this in real time. We're trying to solve this problem after the fact. Why? Because buffers are not measured, they're not visualized. There's no trigger signals or alerts that say, hey, we're overcrowded. Hey, hospital, come give us a hand. There's inadequate communication of overcrowding and buffers are not managed. The only person managing it is this charge nurse. We need the whole system managing this because this is a system-wide problem. So there is no communication, no measurement, no prioritization, no expediting, no escalating, and no improvement. So how specifically did we use TOC buffer management to remove these bottlenecks and improve flow of the entire system? So how did we preemptively manage this? Well, we measured the buffers. The first indication that the ED is backed up is when the lobby starts to back up. So we measured these 2 buffers. How many patients are in the lobby if there was over 4 or if the longest lobby wait time was over 45 minutes. This charge nurse sprung into action, and those actions that she did were exactly what she did when we were over capacity. She sprung into action. Let's get patients moving in, moving up, moving out, get those dirty beds cleaned, and let's get this ED moving. It's preemptive, it's purposeful, and it manages the buffers. A lot of times these are hidden opportunities that need to be found, and they are very readily visible when you start to look for them. Something else we had noticed on our walkarounds was that we noticed that there were dirty beds with linen on them, with a patient gown on them. No patient in the room. This patient had already left, but it hadn't been marked left because the nurse is busy passing meds and taking care of other patients, getting patients checked in, taking care of another emergency. And so what we did was we put an expediter in place. This tech who was standing here would become the expediter during the busiest times, and he would look for these hidden bed opportunities. And he would ask, is this patient left? Yes. He would turn the bed over, it takes about 3 to 5 minutes, and he would mark it as clean and have a new patient put in that bed. This is how you manage your hidden bed opportunities. You look for them and you manage them. So the ED tried to clear itself out. What you noticed in the previous slide was ED escalation level 1. If that did not clear out the ED within an hour, the charge nurse had to notify the nurse manager, hey, we are still backed up. I've tried to clear it out, cannot do so. So the nurse manager would wrap up her meeting and come out, and she would look around and notice, hey, triage is backed up. And she would pull an educator out of the back and have her come and help out in triage. She'd also notice other things. Hey, there's an empty room with no bed. What's going on there? And the young nurse would tell her, hey, that patient went to dialysis, waiting for them to come back. Nurse manager would communicate that we don't do that. The patients that go to dialysis are always admitted from dialysis and go straight to a bed. So let's pull a bed in there, clean the room, and get things moving. And it's important to educate and communicate senses of urgency to the staff, especially the young staff. Most of the tenure of an ER nurse these days is less than 5 years. And so this is communicating, prioritizing, helping her young nurses to actually learn the ropes. So I mentioned that the actual lifespan of our ER nurses, the average tenure is 5 years. And the reason is there's been a lot of recent burnout in emergency medicine due to the stress and due to COVID. Actually, during COVID, there was a ton of stress because we had to change what we did. There was a lot of unknowns with COVID, and a lot of emergency departments actually downstaffed the nursing staff during COVID because our census dropped. And so they dropped the ED nurse census, how many nurses were working. So we need to make our workspace more friendly, more inviting, more efficient, so that we can actually keep those nurses that we've trained up and keep them in our department for a long time. So I mentioned early in the presentation that we had an admission problem. We had a long ED length of stay. So what we did, we assembled a team that would work on this issue, and they would be triggered by if we had a boarder. So this team was led by the executives and involved most of the people that managed the inpatient side of the thing. And we came up with a plan on what to do when we actually started to board. How are we going to react? What actions are we going to take? And that is on the next slide that talks about our escalation policy. So we had a 4-level escalation policy. The first 2 levels were performed by the emergency department, which I've described earlier. But what usually happened during the day is that we became overcrowded, and we became overcrowded because of the admission census. And this, the hospital was triggered into the last 2 escalations, level 3 and 4, based off the number of boarders. A boarder is a person that is admitted to the hospital from the ER but has no bed within 2 hours of that admission. So that would spring the rest of the hospital into a hospital escalation that I'll describe on the next slide. So when we got one boarder, patient placement would initiate level 3. What would happen is an alert would go out over the loudspeaker, and the nurse managers on all of the floors would assist in the discharge process, round on their floors and see if there were any discharges or any dirty beds. They would notify patient placement of those bed numbers. Patient placement would pair that with ED patients that were admitted. She would also coordinate the environmental services to clean those beds, so it would be kind of a seamless turnover of beds. The nurse house supervisor, which is another very educated, advanced nurse, would also help problem solve and see if she could help and get things moving. A hospitalist would actually reevaluate patients. If they knew that somebody possibly was going home, they would reevaluate and discharge. Then they would go to the ER and help with admissions. So if this did not help, we then escalated to level 4, which did not happen very often, but when it did, it was very eye-opening when the CNO and COO would walk around and problem solve and communicate the need for improving things. And I actually find out where needs were and could actually implement on the fly. We need to make this change. We need to make that change. And they are extremely instrumental in keeping this whole thing moving. So what were our results? From just reacting to 2 buffers and escalating through the hospital and manage our beds much better, we were able to actually drop our door-to-doctor time to 21 minutes. We did have a little glitch from spring break. Our volume did increase, but it actually came back down. We also dropped the length of stay significantly for emergency department patients. And this is the most important result that we had because we dropped ED admission length of stay by 2 hours and ED discharge length of stay by an hour. So what does this translate to and why is this so important? Because you're adding capacity when you drop length of stay. By dropping 2 hours in the ED admission length of stay, we admitted 50 a day, so that dropped, it added basically 100 hours of staff bedtime. By dropping 1 hour for 180 patients, that essentially added 180 hours. So we really added 280 staffed bed hours per day. And this is palpable. We could feel the difference from before and after. Before, we had 40 patients walking out a day. After, we only had 4 a day walking out. Like I said, we added capacity. We basically added a fully staffed 12-bed ED pod to our department, which we could have the capacity to see 88 more patients a day. And this, like I said, was palpable. You could feel that you had bed capacity. We had open beds. It just didn't seem to be so chaotic. The patients weren't in the hallways. It did certainly happen at times, but not as often, and we were able to really dramatically drop our left without being seen. So by increasing our capacity, we were able to drop our door-to-doctor times and see patients more rapidly and drop our left without being seen from 40 a day to 4 a day, which added 9% to the entire overall hospital revenue. This is quite amazing. So what was even more amazing is by improving the efficiency of care, our patient satisfaction scores increased 10 points. The overall score increased by 10 points and likelihood to recommend in the ED increased by 10 points. I've seen projects that focus on patient sat not even have these kind of results. Great results, and they were very rapid. So let's recap. How did we get here? So we did this with TOC. It's an amazing, amazing system. So remember the goal. What is getting in the way of the goal? What is our bottleneck? We found a huge front-end bottleneck that we applied queuing theory and lean and actually removed the constraint. So what else do we do? Well, we further identified the constraint. This bed is like our NCX machine in the goal. It sat empty while there was work waiting for it, so we needed to fill that. We needed our charge nurse to take charge and offload our constraint, prioritize our constraint, maximize it, and focus management on it. So we needed to further exploit our bed constraints by using buffer management. By measuring the buffers, we knew when the system was starting to get backed up, and we escalated, got the whole system involved in fixing its problems. So it's time to get to work. I challenge you. We now know what TOC can do. It can improve things rapidly. Let's just get things moving and get things rolling. Let's fix this problem together. And one last thought. We need to remember why we're doing this. We're doing this to prevent harm in our patients. We don't want one more person to be harmed by a broken system that can be fixed. We can fix this system. It's also causing extensive burnout in our staff. Let's fix this problem. Well, thank you guys so much for your attention. Again, my name's Jeff Dreher. You can reach me through these methods. If you want to text me, that would be great. I love solving problems in healthcare and would like to help you learn more on how to fix your hospital system.